All right, so we're going to now move on to Dr. Lee, who's going to talk to us about trauma.
Great, thank you. So at Apsa this year, what was presented was the new Apsa guidelines for management of blunt liver and spleen injuries. And boy, did I learn a lot from that. So what we have here is a 12-year-old male who was a restrained passenger in a motor vehicle collision. He presents to the emergency department with the vital signs as shown: a heart rate of 125, blood pressure of 110/55, and a respiratory rate of 16. His initial lab shows a hemoglobin of 11 milligrams per deciliter, and on examination is otherwise normal, except that he has a seatbelt sign across his chest and abdomen, and abdominal exam shows no evidence of peritonitis. He does get a CT scan, and the CT scan shows a grade 4 splenic injury with moderate free fluid and a contrast blush. In the emergency department, he was given a 20 ml per kilogram of normal saline bolus, and his repeat vital signs show a heart rate of 110, blood pressure of 120/60, and same respiratory rate of 16. So the question we have is, the best next step in management for this patient is admission and A, observation, B, bolus with an additional 20 mLs per kilo of normal saline, C, transfuse 10 mLs per kilo of packed red blood cells, D, selective angioembolization, or E, exploratory laparotomy.
And while people are waiting, just to repeat the case, any comments about this before? Now, this is an example of the same with the opioids. Those of you who are loyalists to this event and have been coming every year, you know that we did this with Dr. Notrika. This is one that's important enough to hit on again. So I'm glad that we're presenting this again. Hopefully we learned some things from Dr. Notrika.
And the correct answer here would be observation. So here are the updated Apsa blunt liver spleen injury guidelines. This was presented at the Apsa annual meeting. Lots of work went into this by the trauma committee of Apsa. And as you know, David Notrika, as well as the rest of the atomic group, was instrumental in developing these guidelines. So as shown for admission, basically, the bottom line for this, which is what I learned at this meeting, was we really want to treat on patients' hemodynamic status. And as they stated before, is the patient bleeding or have recently bled, or is the patient stable? And there are different ways to determine that, and they used a shock index, which was modified for pediatrics, as one way, and that's basically the heart rate over the systolic blood pressure. And based on age, you can determine whether that patient is, you think, maybe still bleeding. And in those instances, then we would recommend an ICU admission. Otherwise, if patients have responded to the normal saline bolus and remain hemodynamically stable, then those patients just need to be observed. Okay. That's probably the biggest key. It's not really based on grade book. I know that that's been, or the grade of the injury. I think that's been shown multiple times in prospective studies. So that's one key point. As you can see under the admission parameters, if the patient's admitted to the ward, then they would need really just another hemoglobin check in 6 hours. They're able to have a regular diet, and there's really no activity restrictions for them. You don't want them jumping up and down on the bed, but they really don't need any additional activity restrictions. Interesting that angioembolization was one of the things people have shown or have chosen for the as one of the answers. And what's shown for the procedures portion is, again, only transfuse if patients are unstable, or again, that critical threshold of a hemoglobin less than 7. If there's signs of ongoing bleeding, then again, you would want to transfuse. Angioembolization in stable patients does not need to be done, even with a contrast blush, particularly in patients with splenic injuries. Those have shown that they do not continue to bleed, but if there's evidence of ongoing bleeding, then that's when the angioembolization should be performed. And obviously, we know for any patients who have continued bleeding, then you need to proceed to the operating room. Questions?
Yeah, we got a lot. I mean, I do. So I want to make sure I review this, because the big thing that I learned last year or 2 years ago was that I was always giving 2 boluses of fluid. I would give fluid. If it didn't work, I'd give another bolus of fluid. Now it's give blood early. Give blood after your first bolus.
Correct.
Is that right?
Correct. So
Okay.
after your first 20 ml per kilo of normal saline bolus, then if patient still requires any additional fluids, then give blood.
Okay, and that's a great point. Some people define bolus as different. Some are 10 cc's per kilo, 20 cc's per kilo. We're saying a 20 cc per kilo bolus of fluid if they're still hemodynamically unstable. So, whatever that might be, whether that's 125 or whatever number we choose, if it's still seeming like they are symptomatic, you would give blood at that point.
That's correct.
Okay, and you would give 10 cc's per kilo of blood.
Correct.
Okay. Other big things to sort of repeat here, if you look, again, I want to highlight things you talked about. Again, this should be available for people to download if you want these, I think. Right, Jay? Because this is a good thing, a good slide. So the activity, you'll notice that it says no activity restrictions. Big change from when we were using the grade book before.
Yes and no.
Okay.
I think the original guidelines actually did not address activity restriction. Well, I guess for in-house bed rests, that was not
Okay.
originally addressed. As some people interpreted it to be, but it really
I must have,
wasn't.
yeah.
So,
Okay.
But basically, that's correct. So now I think the recommendations is if they're admitted to the floor or the ward, then they do not need any activity restrictions. They can go to the bathroom, they can walk around, and all those
see.
other things.
Anyone doing angioembolization ever at their institution? No? Okay.
So
Go ahead.
that was a change because we practice at multiple institutions, and one of our institutions is with a predominantly adult trauma base, and that was one of the things that they would do in 15, 16-year-old kids was angioembolization for contrast, but now we're really putting the brakes on that.
Okay. Also, you don't have to blush on CT. You don't have to do anything about that.
Again, not unless they have evidence of bleeding. If they do have evidence of bleeding, that's when angioembolization would be indicated.
Okay.
And this is a little bit tangentially related, but there's a paper released a couple months ago that was looking at non-invasive monitoring of hemoglobin, where essentially wear like a pulse ox-like device that is able to give a pretty decent estimation of hemoglobin, at least in terms of trends. Have you had any experience with that yourself, or?
We have not had any experience with that, but that would be very interesting because some would advocate that you probably don't even need to monitor the hemoglobin, and your physical exam is probably a better indicator as far as capillary refill and other indications, heart rate, particularly for hemodynamic status.
Question is, curious how many in the audience in a hemodynamically stable patient with a grade 4 splenic laceration with active blush and hemoperitoneum who goes to the floor on admission based on this protocol would order a regular diet immediately?
Want to address that?
Well, I think based on the guidelines, that's what is recommended. Obviously, guidelines are meant for assisting, and every patient will be treated based on the clinician's experience and expertise. But I would personally, particularly in splenic injuries, if they've stopped bleeding, meaning they responded to the normal saline bolus, then I would advocate to advance to a regular diet.
I think that whoever, I don't know who you are, PBHIII, but I'm curious where you're from, so let us know. I love the way you actually phrased that question, because you put it into real life situation, and it made me think, because I'm thinking I follow these guidelines, but you're right. I'd feel a little uneasy, even though I might delay the diet just a little bit. But I think grade 4, yes. Blush. Is there anyone here that would be afraid to admit to the floor with a blush? You guys would all admit to the floor with a blush? You would not?
In my program, we wouldn't have, but
Okay.
I'm learning too.
Yeah, okay.
So the way I interpreted the question was that the patient had a significant injury, has a blush, so that takes some time. During that time, your patient's being resuscitated, getting to the floor. And so in my mind, that could be a 4 to 6 hour process. So by that time, you have a chance to evaluate if the patient's stable or not. And 4 to 6 hours later, if the patient's stable, then starting a regular diet is not unreasonable. It's also not unreasonable to either keep him or her NPO for a few hours or start some clear liquids.
Yeah.
The point is that a regular diet can be started if you feel the patient's comfortable.
Okay. Great point. Dan?
I guess from my perspective, the question is, what is the risk of starting a regular diet? And how many times do you, if it's because you're worried that the patient's then going to go have anesthesia and they should have an empty stomach, first of all, they probably don't have an empty stomach to start with. And second of all, in my career, I think I've taken out 2 spleens for trauma, and I probably shouldn't have taken out one of them. So the risk that you're actually going to go to the operating room is really very low. So if that's the rationale for not starting a diet, then I think you can probably be pretty confident in starting a diet. If the patient doesn't tolerate, you're not going to force them to eat, but putting them on a diet is probably not unreasonable.
Okay.
Yeah, to what Dan said, I think all of us know that what we order and what actually happens
Right. That's all right. That's
are
right.
completely they're not connected, right? You can order the kid a regular diet, but if they don't feel well and if they have a bad hemoperitoneum and an ileus, they're probably not going to eat it.
Yeah.
So
That's a great point, actually. I hate disagreeing with my boss, but I'm fired. I say, what's the hurry? I totally hear you. And even if there was an issue, it's not that you would go to the operating room, you might give more blood or something. You would not have to rush them right then to the operating room. However, I don't see the hurry in just waiting a few more hours. But yeah, but I agree, they're probably not going to be starving after her.
I mean, if they're that sick, they're not going to have a Big Mac and an order of fries.
Right.
Yeah.
You hope.
Okay. Go ahead.
I have a couple questions from the audience. So I know when they're talking about operative intervention, an indication is unstable vitals despite packed red blood cell transfusions. But their question is, how many are you giving?
So the based on the atomic protocol,
Yep.
40 mLs per kilogram of packed red blood cells. So once you reach that threshold, you really should be going to the operating
That's a
room. That's a great question.
great question, great point. Just to say that again, 40 cc's per kilo. Now, is it when you hit 40 cc's per kilo, or is it if you need more than 40 cc's per kilo?
When you need more than 40
Okay.
cc's.
So it's greater than, not equal to.
Right. So if you need more than 40, it's time to go to the operating room, or some places would do angioembolization. But
Correct.
okay.
And then I know we talked about grade +2 for restriction of activity. Would this apply even for like contact sports? So if somebody plays football, you let them go play football in a few weeks after injury?
Correct.
Okay.
Yeah. So Steve Witt had a question. Can you tell us? So give us a background on Atomic. What hospitals the Atomic stands for? I know it's not all of them because I know we don't have a letter in that mnemonic.
Right.
But so what is Atomic in general? You might not know all of it, but what
Right.
is the gist?
So Atomic was started in 2010, and it was a group of level 1 pediatric trauma centers coming together to really study the vital questions for trauma in a prospective fashion. Atomic, I believe, is Arkansas, Texas, Oklahoma, Memphis, and A is another A,
So
Arizona. So.
Akron was part of it too.
And now it's expanded even to more. I believe Akron, I think Kansas City is part of it. And so they really came up with initially a set of guidelines for management of blunt and spleen injuries, isolated injuries. And then they went ahead and prospectively studied it. They've come up with a number of publications based on that. And that really kind of redefined the guidelines that were adopted by Apsa this past year.
Yeah, and just to make a comment about that in general, we need to do more of these.
Yes.
Congratulations to that team for finally putting a bunch of hospitals together to collect real data. We need to do more of that. The Midwest Pediatric Surgical Consortium does something very similar. This needs to be the trend over the next 10 years, that we need more consortiums popping up, because I know that some of them can only have a certain number, but this is the way we're going to get answers to our questions. Any other questions?
For
So,
the,
go ahead.
The transfusion, with the 40 cc's per kilo target, at what point also are you going to be doing the massive transfusion protocol? So like the 1-to-1-to-1 ratio?
That's a great question. I think if that goes back to the original question, if you think the patient is still bleeding, then there's not great evidence in the pediatric literature for the 1-to-1-to-1. There's mixed results with that, but if the patient is certainly still bleeding and unstable, that's when you would want to think about activating the massive transfusion protocol.
Great question.